Hello everyone. My name is Mohammed Jamal. I'm a surgical resident at the Kuwaiti Board of General Surgery, and I'm part of Surg Kuwait team, and I will be your host for today's session. Today's session will be about the pancreatico-duodenal trauma given by our beloved guest from Oman, Dr. Hani Al-Ghadi. Dr. Hani Al-Ghadi is a senior consultant, trauma and general surgery in Sultan Qaboos University Hospital. Welcome with us, Dr. Hani, again, and it's always a pleasure to have you on our platform. Welcome with us.
Thank you very much, Mohammed, and I'd like to welcome everybody to this event, which I hope will be useful and beneficial to all of us. Let me just share my presentation first.
So just a quick announcement, this session will be an interactive session. So Dr. Hani will have some question to the resident and audience. And if you have any question, feel free to either type it in the chat or in the Q&A panel. Dr. Hani, the mic is yours.
Right. So, so today's lecture is going to be about the most difficult and the most challenging trauma to any surgeons, and especially trauma surgeons. It is a trauma to the pancreas and the duodenum. Now, we call the pancreas the surgical soul because it lies deep in the abdomen, and injury to the pancreas results in significant mortality and morbidity for trauma patients, and that's why it is dubbed as the surgical soul. So let me start by inviting you guys to visit Oman once this COVID situation is over, and it looks like it's almost over. Oman is a very beautiful country if you haven't visited, and I think Mohammed Jamal can vouch for this. If you haven't visited, please, you're welcome to come and explore the beauty of Oman. Let's start with the first case, and I don't know if we have Suleiman Al-Awadi. Suleiman Al-Saigh, عفوا. Is he with us? أو عمر العوضي.
He is.
Hello. Assalamu alaikum. Yes, I'm here.
هلا. Who are you? سليمان. كيف حالك
سليمان؟ والله الحمد لله بخير. هلا دكتور.
So Suleiman is going to be the first victim, actually he's not going to be the victim because the first case is a straightforward case. So أبشرك سليمان يعني. All right. So let's go through the case, and Suleiman will go over it and just tell me what to do next. What would you do next? So let's start. So this is a 25-year-old male. He is Al Arabi Football Club player. The Al Arabi Football Club just won the Kuwaiti Football League after, I think, 17 years of not winning it. So he was so happy. He was hanging from a crossbar from the goal. Actually, after scoring the goal, and the goal fell on him, and the crossbar hit his abdomen. So the report from the scene that he was short of breath and complaining of abdominal pain. Now, Suleiman, if this patient comes to you in the emergency room, what's the first thing that you're going to do?
Okay, so I'm approaching this patient with a blunt abdominal trauma. So he's a trauma patient. As soon as I see the patient, I'm going to put the patient on oxygen, attach monitors to him. We want two 14 or 16 gauge cannulas attached, draw bloods and send them for cross-match, CBC, and coagulation. And then I'm going to start with the ATLS protocol. So ask a patient a question, see if his airway is patent.
Okay.
Yeah.
So this is your primary survey. So he has a C-spine collar on. He's talking. He has good bilateral. However, he's a bit tachypnic, so his respirate is 26 per minute. His blood pressure is holding, is 110/70, but he's quite tachycardic. His heart rate is 130 per minute.
Okay. So these are vitals, and I'm going to... Okay, so clearly he has, bruise across the abdomen. I'm going to push fluids, 1 liter of ringer lactate, and see the response.
Right.
And okay.
So this is what you've done. You actually mentioned all the steps. So you put the 216 gauge cannulas, and you drew blood for cross-match CBC and coagulation. You give a liter of whatever, Ringer's lactate or normal saline, and bolus, and you put him on oxygen. Right, so you continue your primary survey. His GCS is 15, and he has no other injuries on exposure. So what would you do next?
Okay, so examine the abdomen. He has a bruise, check for tenderness, do a fast.
It's tender.
Okay, do a fast ultrasound.
Okay,
and
fast?
So, well, X-ray chest and like the adjuncts, X-ray chest, pelvis, fix a Foley catheter. So
chest X-ray is normal, pelvis X-ray is normal. You didn't do the fast because somebody else was playing with the ultrasound machine, so you didn't have the ultrasound machine.
Okay, no worries. Is the patient
there's no other injuries.
Excellent. Is the patient hemodynamically stable?
He's hemodynamically normal. So what would you do next, Sleiman? Would you do a fast now? Now the ultrasound is available. So would you go for fast? Would you do a CT scan? Would you get an abdominal X-ray, or you would get an upright chest X-ray or erect chest X-ray?
Since the patient is stable, the next step would be a CT scan. But I personally would also do a fast ultrasound if I have it just next to me, just to have an idea of what's going on in the abdomen.
Right. So I agree with you. So it's a CT scan, and the right answer here. Actually, I kind of discourage people from doing fast unless they're doing it for training purposes in hemodynamically normal patients, because it's true that they say that it's not going to take much time and stuff, but for me, time is money with all trauma patients. And fast, whether it's negative or positive, you're going to go for CT scan anyways, right?
Yes.
So it's just going to be for your own kind of practice, but it's not going to benefit the patient, decision making. Agree?
Yes, I agree.
Okay, perfect. So this is your CT scan. What do you see?
Okay, so I see some like at the pancreatic head. I think there's like smudging or neck.
Here?
No, more towards the right side.
Here?
Yeah.
Okay.
And also also at the distal, like at the tail, there's
yeah. What do you see
here?
What do you see here?
I'm guessing that the pancreas itself is disrupted or or shattered, like at distally. So yeah.
Okay, so for those who are not familiar with CT scan, so this is a CT scan of the abdomen with IV contrast. You can see here the contrast in the aorta. This is the aorta. This is the pancreas here, and this is the liver and the gallbladder, and this is the stomach and the duodenum coming around the head of the pancreas. And this is, of course, the spleen, and this is the left kidney. This is the right kidney. So if you look carefully, just like what Sleiman has said, of course, it's difficult to comment on just one snapshot of the CT scan. He needs to roll it up and down so it's a bit difficult now to really look, but he got it actually. So this is what we call fat stranding, okay? So there is fat stranding around the tail of the pancreas. And if you can see here, there's a hypodense line that goes across the distal pancreas, right? So, and it almost goes all the way across the distal pancreas. So what would be your diagnosis, Suleiman?
Well, pancreatic injury at the distal, mid to distal or distal pancreas.
Yeah, so distal pancreatic injury, right?
Yes, yes.
Okay, so now the patient is 1.5 hours post-trauma. His vitals are, after your resuscitation, is 118/79. His heart rate is 120 per minute, and his rest rate is 25. What could you do next? Would you admit him in the ICU and observe? Would you measure his serum lipase? Would you get an urgent MRCP, or would you prepare him for distal pancreatectomy? It's a bit difficult.
I'm trying to judge his hemodynamic stability. I mean, he's still tachycardic.
Yeah.
Well, for me, if he's hemodynamically stable, I think admission to the ICU and observation is valid. But that's if he remains stable. If not,
so
then I'm going.
He remains like that. He's tachycardic. He remains like that. However, if you look at the CT scan, what do you think of the injury? Is it a complete transection, or is it your?
I think it's I think it's like just a laceration.
But is it complete or is it partial? You think?
Looks partial to me. It looks partial.
Okay,
I'm not sure.
So maybe because it's not the CT scan is not very clear, which is the usual case with the pancreatic injury. The initial CT scan is not usually that clear, but it's obvious that there is an injury, and obviously the laceration goes across the body. So the radiologist tells you that for him, and he's an expert radiologist, this is a complete transection of the distal pancreas. So would that be your management?
Yes. Yes, I think then it's better to actually go for definitive management and remove that, basically prepare him for distal pancreatectomy and close off the proximal duct.
Perfect. So very good, excellent, Sleiman. Very well done. So initially, because you were not sure about the extent of the duct injury, you wanted to admit the patient in the ICU and observe, and probably repeat the CT scan and do serum amylase, right?
Yes.
We don't usually measure the serum lipase for in trauma. Serum lipase more with medical pancreatitis, but in trauma, amylase is more sensitive than lipase. So that is why. And MRCP, we don't usually do MRCP in the acute phase of management. After you have confirmed with the radiologist that this is a complete transection of the duct, so the main duct has been affected, then the treatment would be distal pancreatectomy. Excellent, Suleiman. Very good. Thank you very much for volunteering. So let's take the next candidate.
Thank you, Dr. Saman, senior resident at the Kuwaiti Board of General Surgery. With us, next resident is also a senior resident at the Kuwaiti Board of General Surgery, Dr. Umar Al-Awadi.
دكتور عمر كيف الحال؟
بخير الله يسلمك. يعطيك العافية دكتور.
So Dr. Umar, you get a 30-year-old Al-Arabi fan who was happy to cross the road and hit by a car by Al-Qadisiyya fan. So on the scene, there is no blood on the scene. Okay. However, the EMS, the ambulance people, they report that he is hypotensive. So again, just go over what you would do for this patient when this patient arrives in the emergency room.
So same. He's a trauma patient. I activate my trauma team. I would like to start simple my team. I would like to assist the patient according to ITLS protocol. I would like to assess his airway, put him in a collar, check his breathing is spontaneously and chest expansion. I would like to check for circulation. I would like to insert 2 large bore, drop blood for workup.
Perfect. So this is basically you're going to do a primary survey, right?
Primary survey.
So yes. So, guys, I never get bored of asking residents to go over the steps, because people think that it is a given and people think that as usual, but then when it comes to the exam, if you're not used to repeating those steps, you might miss important steps. So I like residents to repeat those steps. So perfect, Omar. So yes, so airway, he has a C-spine collar on, he is talking. Breathing, he has a normal chest expansion, normal air entry bilateral. Now, circulation, his blood pressure is 80/40. His heart rate is 120. his rest rate is 18, and his abdomen is as follows. So the car basically hit him and ran over him, and you can see the tire marks over the abdomen. So he has bruises and tenderness over the abdomen, but no peritoneal signs. So tenderness only, like mild, but there's no rebound, no peritoneal, no rigidity.
No rigidity.
So what do you want to do now?
So I will start my boluses, crystalloid boluses, and I would like to activate the blood bank for possible massive transfusion protocol. And I would like to reassess his vital while doing my fast.
Okay, so you want to get fast?
Yes.
Okay. So again, I don't get tired of mentioning those points. So you're going to attach the patient to a monitor, which is already attached in this case. You have to mention two 16 gauge cannulas, not large bore, 16 or 14 or 18 gauge cannulas. In both antecubital fossas, you have to specify where you're going to put the cannulas. And as you said, you're going to send blood for cross-match, CBC, and coagulation, and you're going to alert the blood bank for possible massive transfusion. And you're going to give 1 liter of normal saline IV bolus and 100% oxygen. Okay, perfect. And you continue your primary survey. His GCS is 15. He has normal pupillary response and no other injuries apart from the abdomen. So your chest X-ray is normal, your pelvis X-ray is normal, and you do the fast, and the fast is positive. Now, you continue your secondary survey. You'll notice that there is a swollen left lower limb and secondary survey. And after you resuscitate him, his blood pressure goes up to 110/70, and his heart rate is 105. So the heart rate goes down, and the heart rate and the blood pressure goes up, and he stays up, like he does not drop his blood pressure. So what would you want to do next?
So he's a transient responder. I would like to check for peripheral pulses.
No, he's not a transient responder. He went up and he stayed up.
Okay. So he responded to the fluid station. Yeah. Mm-hmm. So I would like to, for the swollen tibia, I would like to check distal pulses and
all intact.
All intact. I would like, if the bone is not, I would like to reduce the bone and put him in a back slab.
Perfect. So you've done that. You have stabilized the fracture. And then where would you want to go next?
If the patient remains vitally stable, I would like to go to the CT room.
Okay. So these are the options. Would you do a CT abdomen? Would you repeat the fast? Would you take him directly for laparotomy? Or will you take him for diagnostic laparoscopy?
If you remain the same, I will go for CT abdomen.
Excellent. I think that's the right answer. So even though the fast was positive initially, you are still resuscitating the patient. The initial hypotension, you have to see the response of the patient to your resuscitation. Now, as Dr. Omar mentioned, you have to judge if your patient is a transient responder, non-responder, or a responder. Now, this patient is a responder. He responded to your resuscitation, right? So if he's a responder, he goes to CT scan. Now, this is the result of the CT scan. Can you tell me what you see?
So on both images.
Let's start with this cut of the CT scan.
So it's CT abdomen with a contrast of the abdomen. I can see that there is a splenic injury. That's
right.
The most obvious laceration, yes. And there is also I can see free fluid just next to the spleen.
Perfect. So this is a clear splenic laceration going through the spleen, and you can see some free fluid around the spleen, whether it's free or subcapsular, we don't know, but most likely it's free fluid, right?
Yes.
What would you want to know if you see splenic laceration? What is your next question about the spleen?
If there's arterial flush.
Excellent. So there's active extravasation or no active extravasation. Remember, this patient is hemodynamically normal so far.
Yes.
Okay, except for the tachycardia. So yeah, so there is no active extravasation from the spleen.
Okay.
Now let's go to the other view. So you go down a little bit, and then you see this this finding. What do you think is happening there? It's not something that you see every day, so it's okay to miss it.
Yeah. I think there's a duodenal hematoma.
Mumtaz. Excellent, Yamar. So you can see this is the duodenum here, and this is the liver, this is the kidney, right kidney, this is the left kidney, this is the aorta, and this is the IVC. And you can see here the duodenum, it's edematous and thickened, and the lumen of the duodenum is thinned, so it's small. Usually the duodenum has a little bit of ballooning, and there is a hematoma surrounding the duodenum. So this is a duodenal hematoma in this patient, right?
Yes.
No other injuries have been identified in this patient. The pancreas looks okay. So on the CT scan, طبعا. So what would you do next? Would you insert a nasogastric tube, consider TPN, and monitor his hemoglobin? Or you're going to take him for urgent laparotomy? Are you going to do an urgent MRCP, or are you going to do an urgent ERCP?
If the patient remains vitally stable and there is no sign of duodenal perforation, there is no free air, I would like to put an NGT, consider start TPN and serial hemoglobin, and admit him to the ICU.
Perfect. So that is the correct answer. So for duodenal hematoma, and the patient is hemodynamically normal, the treatment is usually conservative. You're going to put a nasogastric tube, put the patient on TPN, because most likely this patient is going to have a prolonged NPO, and monitor his hemoglobin, because remember, he has a splenic injury. Excellent. Super. Thanks very much. Thank you very much, Amar.
Thank you, doctor.
Can we have the next?
Amar Al-Farouk for answering the case. We will have again with us Dr. Sleman, who is happy to take the third case. So,
Okay.
Dr. Sleman.
Okay, good.
It was easy at the beginning.
All right, so Dr. Sleman, you have a 20-year-old male who was stabbed in the anterior abdomen, not related to Al-Arabi at all. Stabbed in the anterior abdomen. On examination, he arrives in pain, and he's oriented, so he's not in shock. He's just complaining of pain, and he, according to the EMS, he was hemodynamically normal. So since you've already mentioned what you would do previously, so we're not going to go through this again. So he has a C-spine collar on. He's talking. He has good bilateral air entry. His breathing at a rate of 26 per minute. So he's tachypnic. His BP is 110/70, and his heart rate is 130 per minute. So he's tachypnic, tachycardic, but his BP is 110/70. Sorry, this is not the right picture. So he has a stab wound. You do all your resuscitation. And his GCS is 15, no other injuries. So he has basically, the picture is that he has a stab wound in the epigastric area. So what would you do next?
Okay, this patient has...
This is the picture of the stab wound. This is the picture of the stab wound.
Okay, but no knife, just the stab.
Yes.
Okay, right now the patient with fluid resuscitation, he's hemodynamically stable. I would proceed with a CT abdomen.
So yeah, so after fluid resuscitation, this is his blood pressure, 120/80. His heart rate is 100, and his rest rate is 18 per minute. Okay, and this is the laceration in the epigastric region.
Yeah, I need this. I'll proceed with a CT chest and abdomen.
CT chest and abdomen. Okay, so this is his CT abdomen, and you can see here. what do you see here?
I think that I see there is a laceration. I think this is the duodenum.
Right.
That's completely transected, and
okay.
there's fluid and blood in the abdomen.
Right. So there's a hematoma, right?
Yeah.
Okay. What is this?
Stomach.
Stomach. So if you imagine the continuation of the stomach, then what is this going to be?
The duodenum, or the
Yeah. So this is the duodenum, okay, and this is the second part of the duodenum, and it comes this way. So what would this be?
The third. Oh, the pancreas.
Yeah. Which part?
Okay. So the pancreatic. So that's the pancreatic head.
Head, right?
Yeah. Yes.
So this is the junction between the pancreatic head and the body, right?
Yeah.
Actually, when you run it is the junction between the body and the tail. So
okay.
This is if you run it down. So it's the junction between the body and the tail of the pancreas. There is a large hematoma here going across the pancreas. So what would you do next?
So I take the patient for a laparotomy.
Laparotomy. Why not
Yes.
ERCP? Why not ERCP?
I think he has a complete, like a grade. I think he has a grade 4 injury, with complete transection of the duct,
Right.
and therefore he would need like ERCP. I don't think would be enough to put a stent.
So this is one reason, is that he has a complete transection of the pancreas. Any other reason that you would go for laparotomy?
He has a penetrating abdominal injury and we need to look for other injuries as well.
So basically, this patient was found to have a through and through gastric penetration, and penetration into the junction between the body and the head.
Okay.
So what would you do?
Okay. So we take it one by one. There's a gastric injury, and there's a through and through, and there's a pancreatic injury.
Right.
Okay, so the gastric injury we can repair if it's a clean cut and it's a simple surfaces are next to each other. We can just primarily repair. Right. Now we go to the pancreas. We said that it's between.
One second, Dr. Suleiman. We don't say we can. We have to say I will.
Yeah, I will. Sorry. So yeah, I'll repair the gastric injury with primary repair. And then going to the pancreas. So we said it's a complete transection between the body and tail. Right. So it's more of a distal. I have to examine for the SMA and SMV if it's distal to it. Then I'll go for so I will do a distal pancreatectomy plus splenectomy. Right. And proximal ligation of the proximal pancreatic duct.
Excellent, very good.
Of course, with the repair of the stomach.
Mumtaz. Thank you so much.
Thank you.
Do we have Omar next, or we have another candidate?
I'm ready.
Okay.
Dr. Omar ready.
So, Dr. Omar, you get the hardest case because it's domestic violence. So you get a 40-year-old man who had the fight with his wife. She punched him multiple times in the abdomen. So he went to the local hospital, which is a peripheral hospital. He was admitted there for 10 days. The initial CT showed that he has a pancreatic head injury from the repeated punching. So they took him to surgery. And when they took him to surgery, they did a laparotomy. They went in, they found a big mess, a big hematoma in the head. So all what they did is they did a limited debridement and they put drains and they came out. Okay?
Okay.
So after day 10, they call you because you're in the main hospital. What is it, Al-Amiri?
Al-Amiri, yes. Al-Amiri.
Right. So you're in Al-Amiri, they call you because, doctor, we have this guy and he's not getting better. This is 10 days now. And we want to transfer this patient to you because there's a persistent drainage from the drains, okay? And they don't know what to do. So the patient comes to you, you examine him, he's talking. He has reduced air entry bilateral in the lung, and he is tachypnic. His blood pressure is 110/70. Again, he's tachycardic. The abdomen is distended and mildly tender. There's no peritoneal signs. Again, his GCS is 15 and there's no other injuries. This is his CT scan. He comes with his CT scan. And this is his CT scan. Can you tell me what you see in the CT scan? I know it's a big mess, but this is what actually, this is my patient. This is not an imaginary patient.
To be sure, I'm not sure, but I can see there's 2 drains. I think there is 2 drains. I can see the drain next to
Let's start with the easy things. Don't start with the drains. Let's start with the easy things. So what is this?
The liver.
Liver and?
The spleen.
And this is a CT
Abdomen with IV
with
control.
IV, right?
Yes.
Now,
Yes.
this is the aorta, right?
Yes. This is IVC.
What would this be?
IVC.
IVC. What is your comment on the IVC? Can you look at the IVC here? What did you think? What do you think about the IVC in this case? Is it well distended or collapsed?
No, collapsed.
Collapsed. So why do you think this this patient would have a collapsed IVC?
Because he was in shock initially.
Yeah. So it's probably hypovolemic, right? So hypovolemic. Okay, and this is something that you also should look for whenever you do CT scans for patients who are in shock. You have to look at the IVC. If the IVC is slit-like or collapsed, then this patient needs volume, right? Now, the other reason why the IVC would be collapsed is that he might have a big collection here that is compressing on the IVC, right?
Yes.
Because remember, he's injured in the pancreas. The pancreas is a retroperitoneal structure, so if you have a big hematoma in the pancreas or collection, it can compress on the IVC. Right. So then we come to the fun part. So this is, what do you think? What do you imagine that this would be here?
This is the remnant of the pancreas. Yeah.
So this is the pancreas with a lot of necrotic tissue. So it's a big mess, right? And as you can see, these are all parts of the drain. Here. But because it's a CT scan with different cuts, you will not see the drain as one tube, but you would see like parts of the drain. In the scan, and there is a collection here. You see, there's a collection here just superior to the pancreas, and of course, this is the transverse colon, and the transverse colon is collapsed. Okay, so I'll play a video of the CT for you, so that you just have to see the picture here. So you can see this is the liver. This is the spleen. The gallbladder is distended, and you can see the collection here. And you can see the pancreas and the liver. And this is the drain here. Okay. Okay, I'll play it again for those who want to see. Remember, look, there's also pleural effusion here. That's why he has reduced air entry. But there's a collection here. There's a collection here. There's a big collection here. And this is another collection. And the drain is within this collection. Okay.
Okay.
So what would you want to do next? So would you take him for laparotomy and wash? Would you do ERCP and stenting? Would you put another percutaneous drain, or would you upgrade the current drain? Upgrade means put a bigger drain in the same place of this drain. So what would you want to do next?
Actually, I want to do two things. First, I want to evaluate the duct itself. I want to know what the level of discontinuity of the duct.
Mm-hmm. So how would you do
that? With ERCP, especially like his pancreatic head, consider ERCP.
Right. Yeah, so that's the actual right answer. And that's what we did in this patient. So we did an ERCP and stenting for him. The last thing you want to do is to go back and do a laparotomy in this patient 10 days after he had another previous laparotomy. That will be a recipe for disaster. To go in that mess, especially with the pancreatic injury. You know, if you look at the surgical books, it looks nice and the drawing is clear and you see the transection, but in real life, it's just a big mess. And then you will end up with an open abdomen that you cannot close, and with all the complications of an open abdomen. So I would not go for laparotomy, especially this patient is not like going into septic shock or anything. He's sick, but he's not in septic shock. Another percutaneous drain is not going to make a big difference. The main complaint of this patient coming to you is that he has a lot of drainage from the drain that he has. So the drain that he has, there is no problem with it. It is not blocked. It is draining. But you have a lot of leak of pancreatic fluid, right? Mm. So in this case, the best thing to do, and as you said, the injury is in the head. So you want to know how the duct is, and you want to try to put a stent across the laceration and bridge that laceration. this is actually what we have done, and we did an ERCP. We put a stent across the laceration, and this patient stayed with us for, I think, a month and maybe a half, and eventually he went home with no other surgeries. The collection has subsided, and the injury has healed without a need for intervention and need for complicated interventions. So yeah, so thanks a lot, Dr. Omar and Dr. Sulaiman, for volunteering. You guys are very courageous, and I wish you good luck.
Thank you very much, Omar, and thank you, Dr. Saman.
Right. So let's. So this is the video of this patient, and after stenting. Okay. This is the nasogastric tube here, but you will see the stent coming soon, and this is the other drain. And this is, you can see here, this is the stent here in the pancreatic duct. Okay. Good. Right. So, so let's talk a little bit about pancreatic injury. So this is a boring part where I get to speak and you guys get to listen. If you have any questions, you can just put it in the chat. I'm going to put the chat box open. So if you guys have any questions, just let me know. Write it in the chat, and make sure you put to all panelists and attendees, and not just to all panelists. So everybody attending this lecture can also see your question if you have any questions. I'll try to answer as many questions as I can. So let's talk a little bit about pancreatic injury. So morbidity and mortality of the pancreatic injury. The mortality ranges from 30 to 35%, 3 to 35%, depending on many factors which we're going to talk about later on. However, if untreated or undiagnosed, which unfortunately we see quite often, mortality can jump to 50 and up to 90%. And that's why we have to be very, very, very careful not to miss pancreatic injuries. Now, if you manage and to deal with the pancreatic injury, you still have to suffer with, or you have to deal with the morbidities that serious morbidities that come after the pancreatic injury treatment, whether it is surgical or conservative, including fistulas, sequelae of the other injuries that are associated with the pancreatic injury. So it has quite a bit of morbidity, 30 to 40% morbidity. That's very, very high. And this shows you how significant pancreatic injuries are and how you should be very, very suspicious. We get calls from the trauma emergency doctors, and we go down to see a patient who had involved in an MVC, and they would only do a CT head and C spine, and they would not do an abdominal CT. The reason why, they tell you because the abdomen is soft. And I did a fast, and the fast was negative. But fast does not tell you anything about the retroperitoneum, does not rule out duodenal injury or pancreatic injury. And if you rely on fasts and you rely only on your clinical examination, you're going to be missing a lot of injuries in the abdomen. So with the mechanism, you should have a very high index of suspicion and scan these patients, get a CT scan done. Case 2 wasn't grade 3 and 4 splenic laceration with perisplenic laceration. Chandan, I can't remember what the second scenario, Chandan, there was no, the splenic laceration. Yeah, no, Chandan, sorry, Chandan is asking, again, you put the question to all panelists rather than panelists and attendees. So I'll have to read the question. Dr. Hani, I would like to raise my doubt regarding case 2. Wasn't grade 3 and 4 splenic laceration with perisplenic laceration, I think you mean hematoma, an indication for exploratory laparotomy with splenectomy? No. Grading of splenic injury is only for radiologists to have fun. Has nothing to do with the decision to go for surgery. The only decision to go for surgery for splenic laceration is if the patient is hemodynamically abnormal, or if there is active extravasation from the spleen on CT scan. Doesn't matter what the grade is. It could be grade 1 with active extravasation, or grade 4 with no active extravasation. So if there is active extravasation and you don't have angioembolization facility. So if you can't go for the angioembolization, then you go for surgery. In addition to that, if you admit the patient, he's hemodynamically normal, you admit the patient, and he keeps requiring blood transfusion. So he keeps dropping the hemoglobin, and you keep transfusing the patient. So more than 6 units of transfusion on admission, that's also an indication to go for surgery. But the grade 3 or 4, this is just radiologic grading, which we don't really base our decision on it. Okay, so let's go back to pancreatic injury. So we agreed that pancreatic injury has high mortality and high morbidity, right? Now, morbidity and mortality, what does it depend on? What are the predictors of outcome? First of all, the mechanism of injury. Is it penetrating or blunt? And in penetrating, is it a gunshot? Is it stab wound? Is it shotgun? So stab wound is much better than a gunshot, and gunshot is much better than a shotgun injury. So the mechanism of injury is definitely important. Associated injuries. So depending on how many associated injuries, we'll talk about this later on, the mortality and morbidity is worse. Pancreatic duct status. Whether or not the pancreatic duct is involved also affects the outcome. And finally, time to diagnosis. This is the most important, along with the pancreatic duct. Time to diagnosis is very, very important. If you delay the diagnosis, the prognosis becomes bad. Now, let's talk about associated injuries with the pancreatic injuries. So if you look at the injuries that cross 40% association with pancreatic injury, usually vascular injuries, liver injuries, and gastric stomach injuries. Also, spleen and kidney carry more than 20% chance of injury with the pancreatic injuries. Now, how significant are associated injuries in terms of mortality? If the patient has 0 or 1 associated injury, the mortality rate is 2.5%. If the patient has 2 or 3 associated injuries, the mortality rate jumps to 13.6%. And if 4 or more associated injuries, it's about 30% mortality. And 30% mortality is a very, very high mortality. Now, should we measure the amylase in these patients? We should measure the amylase. However, we have to know that the sensitivity of the amylase is only 50%. Okay, sometimes up to 80% in some studies, but majority of studies quote figures around 50%. It is not reliable if measured less than 3 hours after the injury. So in the first 3 hours, measuring the amylase, it is not reliable at all in predicting or diagnosing pancreatic injuries. However, after the 3 hours, the negative predictive value is very high. It's about 95%. So if it is negative, then and you're still in doubt after 3 hours, negative amylase has a 95% chance to be correct. It is definitely more sensitive than lipase in trauma, which is the opposite of medical scenarios with pancreatitis, where lipase is more sensitive than amylase. What about CT abdomen in diagnosing pancreatic injury? CT abdomen is a standard of care for the diagnosis. It carries a sensitivity of 80%, so you still have about 20% chance of missing the injuries, and 40% false negative rate. And the later you do the scan, the more accurate the scan is. So if you do the scan immediately versus you do the scan a day or 2 later, definitely the scan 2 or 3 days later is more sensitive to pancreatic injuries than the initial scan. Now, what about ERCP and MRCP? The moment we hear pancreas, we think ERCP, MRCP. We have to make sure, and we have to know that ERCP and MRCP, they have no role in unstable patients. So if the patient is unstable or abnormal, hemodynamically abnormal, no MRCP, no ERCP. This is one. In the acute phase of the trauma, there is no role for ERCP and MRCP. So it's basically reserved for delayed scenario. So after a few days of the pancreatic injury, with persistently high amylase, persistent abdominal pain, and unclear CT finding of the duct situation. So if you don't know what's happening with the duct on repeat CT scan, then you go for MRCP/ERCP. That is the query duct status. Now, the surgical approach. First of all, if you decide to go and approach the pancreas, you have to pray. Very important prayers in whatever religion you pray with. You pray. You will need all the prayers you have, because it's one of the most difficult surgeries you're going to encounter. And what should you do? First of all, get an expert to be with you. Do not be a hero, and do not be arrogant, because the pancreas will always win. If you are arrogant, the pancreas will always win. So it's a lose-lose situation for you. Get an expert. If you have a hepatobiliary surgeon in the house, if you have an experienced trauma surgeon in the house, get them along. Even an experienced general surgeon, experienced with the pancreas and the hepatobiliary surgery, get that person with you. If you don't have a good support, I would say refer the patient to another hospital. Do not go and explore pancreas on your own if you're not an expert. Then you have to determine the grade of injury. We'll talk about the grades of injuries after the slide. And you have to rule out other injuries, or you have to, before you go, you have to rule out other injuries in the CT scan, if you can, if the patient is hemodynamically normal. Then you call the OR, you have to prepare all these sets: laparotomy set, vascular set, and thoracotomy set. Okay, they always have to be there in the room. And of course, if you have the cell saver available in your hospital, also keep it readily available. And then you have to decide in your mind: are you going to go with a damage control mode, or you're going to go for definitive management of this patient? So, and you have to convey that to the people that you're operating with. You have to talk to the anesthetist, you have to talk to your assistants, you have to talk to the nurses, and you tell them, we are going to go in a damage control mode. Okay, so everybody is aware of what you're going to do. Now, when you go into the abdomen, let's assume it's just purely a pancreatic injury. The way to access the pancreas is you open the lesser sac through the gastrohepatic ligament. Gastrocolic ligament. You do full cauterization of the duodenum, as well as the hepatic flexure of the colon. And from the other side, you do full mobilization of the spleen and the splenic flexure of the colon, rather than the spleen, not the splenic flexure of the colon. You do a full mobilization of the lateral attachments of the spleen and bring the spleen to the midline so that you can examine the distal part of the pancreas. With these three steps, you will expose the whole pancreas. So you can see the whole pancreas, and that's the only way that you can examine the pancreas as a whole. Then, if it's a penetrating injury, try to follow the track of the penetrating injury. If it's a bullet or a knife, follow the track from the skin all the way down to the pancreas. Do not start from the middle. Follow the track, because you want to see what other structures have been injured and where exactly the injury would have gone into the pancreas. If you can't visualize the duct, you can give CCK, which can also help you in visualizing the duct by seeing secretions from the duct, pancreatic juice. And if not at all possible, then you can do an intraoperative cholangiogram. I will show you how we do the intraoperative cholangiogram. So this is the mobilization of the spleen. We fully mobilize the spleen and bring it to the midline, and you can see it is outside the abdomen, and you can see the pancreas very nicely displayed This is the distal pancreas, and along with the body. So that is how you should mobilize the spleen and the lateral parts. This is an intraoperative cholangiogram. The way we do it is you get the gallbladder, you get a hole in the gallbladder, and you insert a catheter through that hole, and you inject contrast through the gallbladder, and you visualize the whole biliary tree. You're going to also visualize the duodenum, and you're going to visualize the pancreatic ducts. You can see the pancreatic duct here clearly visualized, and you can see here there is a leak from the pancreatic duct. You can see the leak coming out from the pancreatic duct. So this is a clear cut diagnosis of pancreatic duct injury, common like main pancreatic duct injury, using an intraoperative cholangiogram. We do it through the gallbladder. Now, how do we classify or how do we grade the pancreatic injury? Now, these gradings are not radiological grading; these are surgical grading, so that these gradings are important. Okay, so there is grade 1, 2, 3, 4, and 5. So basically, grade 1 and 2, there is no injury to the main duct. In summary, grade 1 and 2, there is no injury to the main duct. Now, grade 3, where you have injury to the main duct, but distal laceration, okay, in the distal body. In grade 4, you have injury to the duct, but proximal in the head, okay? And grade 5, you have a massive disruption of the pancreas along usually with the duodenum, okay? But they don't mention the duodenum here, but we'll talk about it later when we talk about the duodenum injury. So if you look here, grade 1 and grade 2, there is no duct injury. Grade 3 is distal duct injury. Grade 4 is proximal duct injury. Grade 5 is massive destruction to the head. So how do we treat, how do we approach these injuries? So grade 1 and 2, because there is no duct injury, actually it constitutes 80% of all pancreatic duct injury, so that's good news. Usually it's treated by conservative management, observation, and sometimes we take the patients for wide drainage if we think that there is necrotic tissue that needs debridement. Or if you are in the abdomen for another reason, like for splenectomy, for example, or bowel injury, and then you have to deal with the pancreatic injury, you just put drains and come out, nothing, you don't do any other major intervention because there is no duct injury. In addition, you should also think of giving the patient a feeding jejunostomy if you're operating. If you're in the abdomen for some reason, you have to think of whether or not this patient would require a feeding jejunostomy. Now, grade 3, which is distal, as we have mentioned in the scenarios that we're given, is treated by distal pancreatectomy. So we remove about 60 to 70% of the body of the pancreas. Sorry, by removing the body of the pancreas distal to the superior mesenteric vessels, you're going to remove about 60 to 70% of the pancreas. We usually remove the spleen with the pancreas because when we operate, it's a mess. That's not the time to preserve the spleen. However, there are reports that preserving the spleen have benefits. But remember, it has also been documented that if doing a spleen sparing surgery, first of all, takes more time in the operating room and is associated with more blood loss. So I don't usually do a spleen sparing distal pancreatectomy. I just go for distal pancreatectomy. Now, after you remove the distal pancreas, what should you do? First of all, you find the duct. You can see the stump here. You find the duct and you put a catheter through the duct and get a cholangiography through the duct. That will help you visualize the rest of the duct. And in addition to that, it will prevent or eliminate the need for doing ERCP post-operatively. Then, once you have identified the duct and you've done your cholangiography, or pancreatography in this case, sorry, then you close the duct. How do you close the duct? There are two techniques of closing the duct. One is by suturing it using a 2-O proline U-stitch. and the other one is by stapling, using a stapler and stapling the distal end. Okay, we use a TA and staple the distal end. And not much difference between suturing and stapling the duct or the distal end. So let's go to the so grade 4 and 5, basically the proximal injuries. You ask yourself, is the duct injured or not? If the duct is injured, then we have to operate on these patients. We do closed suction drainage, plus ERCP and stenting. If there is no duct injury, just damage to the head, then we just put drainage. We drain the necrotic area in the proximal, so that's grade 4 and 5. In the distal ones, if there is duct injury, no, then just put a drain. If there is duct injury, yes, then you do a distal pancreatectomy. If it is indeterminate, you decide whether it's high probability or low probability, and also get an intraoperative cholangiogram just to make sure of the duct. Now, I'll just get out of this and see if I have another slide that I missed. No, I don't have a slide that I missed. Okay, good. So that is with regards to the pancreatic injury. Let's move on to duodenal injury. So in duodenal injury, the background, it is 5 to 7% of all trauma, so it's very rare. However, when it happens, morbidity and mortality is about 25%, so that's very high morbidity and mortality. Associated injuries are liver, colon, small bowel. These are the most common, but it can also be associated with any other bowel injury. Again, the AAST, American Association of Surgery of Trauma, also graded the duodenal injury, grade 1, 2, 3, 4, and 5. So grade 1 is single hematoma, and if there's a laceration, it's partial thickness laceration. Grade 2, so that's basically duodenal hematoma, the scenario that we gave. Grade 2, more than one hematoma, and less than 50% or less than 50% circumference of the duodenum lacerated. Grade 3 laceration, there's no more hematoma. So about 50 to 75% of D2 and 50 to 100% of D1, 2, 3, and 4. Grade 4 is more than 75% of D2, and it involves the ampulla or the distal CBD. Then grade 5 is major disruption of the duodenum and the pancreas at the same time, in addition to devascularization of the complex, duodenal pancreatic complex. So let's see how we treat these grades. So grade 1, duodenal hematoma, we have mentioned in that scenario, mainly is seen in children. And it usually comes as a delayed presentation where the patient is discharged and then they come with symptoms of bowel obstruction, vomiting. Treatment is mainly conservative management, and they usually respond to nasogastric tube and TPN. If they don't respond to conservative management after 10 days or 2 weeks, then you should think of surgical options. Now, grade 2 and 3, where there is no CBD injury, okay, so grade 2 and 3, let's go back and show you. So grade 2 and 3, there is only duodenal laceration, but there is no CBD involvement, right? So in the grade 2 and 3, you do debridement and primary anastomosis. So usually you can just debride and freshen the edges and just do primary anastomosis and put drains around it. Or if you resect, you do primary anastomosis. If you don't resect, you can just debride and do primary repair. And put drains around it just to monitor for leaks. Some people do pyloric exclusion as well, but majority of people do not do pyloric exclusion if there is no CBD injury. Now, grade 4, when you have a duodenal laceration with CBD involvement, Then there are two ways of handling this. One is doing what we call a Roux-en-Y jejunal limb, where you divide the jejunum and bring the jejunum up and patch the duodenum, okay, serosal patch on the duodenum, and then re-anastomose do a jejunal jejunostomy. So that's called Roux-en-Y jejunal limb, or pyloric exclusion. I'm more familiar with the pyloric exclusion, where you do a gastrotomy and you grasp the pylorus with Alice forceps, and you take stitches with silk stitches, and you just whip stitch it and close the pylorus. This is one. So you've isolated the pylorus, and then close the duodenal injury and give the patient gastrojejunostomy, so that when the patient feeds, it goes into the distal limb. And also you want to decompress the duodenum in the gastrojejunostomy. So that is pyloric exclusion. Now grade 5. Grade 5, basically, which is complete disruption of the pancreas and the duodenum. That is a very major injury. And what we do basically in grade 5 is debride, put drains and come out, and try to close the duodenal injury, or a Whipple procedure if need be. But it is very, very morbid to do a trauma Whipple procedure. So you have to really make sure that you have the expert with you, somebody who is used to doing Whipples. Don't do it for the first time in trauma for sure, because that is basically carries a very, very high mortality. So in conclusion, pancreatic injury is a complex and frequently missed injury, unfortunately. You should always have high index of suspicion based on mechanism. Do not rely on your hand examination or fast examination. Always get a CT scan done. And if really you're suspicious the CT scan is not clear, get an amylase and admit the patient for observation and repeat the CT scan after a day or two. Always plan your approach well. Okay, always know the other injuries, know your capabilities, get the best expert with you to help you before you go into the surgery. And finally, if you remember, missed injuries carry very, very, very bad outcome for the patient, so you better call your lawyer. Thank you very much and good luck. If you have any questions, I'll be happy to answer them.
Thank you very much, Dr. Hani Al-Ghadi, for this informative session. Always a pleasure to have you on our platform. If anyone has any question, please feel free to ask Dr. Hani in the Q&A panel or in the chat.
I can't open the Q&A for some reason. Only the chat is open.
All right, well, 1 second. We'll let Hadi maybe upgrade you to the co-host so you can see the Q&A. So far, there is a question from the anonymous attendee. Does the pylorus stitches equal an unfired stapler?
Yeah, you can also staple the pylorus, but don't use a cutting stapler. Just use a stapler, not cutting stapler, because the problem with using a stapler is I've seen it. People try to do pyloric exclusion with a stapler, and then they fire the cutting part. Do not fire the cutting part, just the stapling part. So do not use the cutting stapler. Just use the TA, which just staples. Now, the good thing about it is that usually it opens by itself, and if it does not open by itself, you can actually open it by endoscopy. You don't have to go and operate again.
All right. There's no more question. So we'll end the session here. Thank you again, Dr. Hani, for this amazing session. We will pull out the QR codes for the next surgical weight session and now. So feel free to take out your phone and register for the upcoming session. We have the next session will be the ABC of research with Dr. Sarah Yoha. And next week, surgical fix session will be with Dr. Alexander Lee from University of Columbia. And a talk about the management of gastroesophageal reflux diseases. And don't forget to register for the surgical debate of next month. And the title will be soon revealed on the Instagram. So thank you again, Dr. Hani. Always a pleasure to have you with us. And
thank you.
Have a great night.